want to keep track of time. And
clock in here. That's right.
exactly.
And I'm charging my watch, and so
no worries. Like I said, I just put my right here, and every so often I'll just check in and either start talking faster or slow it down. Take a few more questions.
All right. I think we'll go ahead and get started. I think we're at 11:30, aren't we?
Yes. 11:30.
1 minute. Yeah. Okay. So, if you could take your seats. We thought we wouldn't do our usual circle just because we have quite a few people here today, which is great. Circle might be a little hard to organize. Well, we are delighted this morning to welcome Dr. Harleah Buck, who is director of the, how do you say that?
Csomay.
Csomay.
It's a family name, an old Iowa family from Bohemia, and what would be Czech Republic today.
Yeah.
So the CS.
So without further ado, I'm just going to turn it over to you because I'm sure you have lots to say, and we just are so happy that you're here. Thank you for coming.
Thank you so much for the invitation, Lori and Bob. Really appreciate it. Well, first and foremost, you've heard my official name, Harleah Buck, Dr. Harleah Buck, but my friends call me Leah, so please feel free to refer to me as such. We're neighbors of yours from Coralville. We live over a little bit closer to Brown Deer. But we've been in Iowa since 2020 when I was recruited to the University of Iowa to fill the Sally Mathis Hartwick Professorship in Gerontological Nursing and to direct the Barbara and Richard Csomay Center for Gerontological Excellence. So when I was invited to come this morning, I said, you know, it sounds to me like this is kind of going to be our people. Do you mind if I talk a little bit about the Csomay Center first before we jump into the topic that I've been asked to speak upon, which is spirituality and aging? And so I'm going to do this, and probably at about the halfway point we'll have an inflection and I'll switch to that other. But you'll see that they're not two separate talks, but they sort of blend over because I am one of the research faculty, and I'm going to be talking about first my clinical practice as a nurse with spirituality in older adults, and then I'm going to be talking about my research related to it. So without further ado, first and foremost, just a little bit, and for those of you who have ties to the University of Iowa, whether you're alums or retired, actually the University of Iowa's history in gerontology, or the study of older adults, is very historic. You're right to be proud of the university in a lot of different ways, but particularly in this area. It was the first university in the Midwest that offered a PhD in gerontology for nurses, and indeed most of the surrounding universities in the Midwest, their gerontology faculty came out of Iowa. They were either PhD students here or postdocs, so whether you're looking at Mizzou, SLU, Madison, Ann Arbor, it just goes on. So really, that's what, I was at the University of South Florida in Tampa when I was recruited here. That's what made me reverse migrate. When every other Iowan was heading south at this age, I was willing to head north. And it has to do, and you can see the timeline, that the first program was established in '89. They got funding from the National Institutes on Health to set up a center. They then obtained money from the John A. Hartford Foundation to carry on. A NIH-funded center just is funded and then it goes away. So this carried on the funding, and then finally obtaining a gift from Barbara and Richard Csomay, who interestingly enough, while they were UI alums, were not in the health sciences. She was actually the first female music director in the state of Iowa, but she had been a family caregiver. And she knew that there was really important things that needed to be done to both prepare the workforce, but also to increase the evidence base. And in particular, Barbara lived longer than Richard, and they did not have any children. She had some property, family property, in Iowa, and so made an estate gift. And so that accounts for the gap between 2011, when the gift was made, until the estate was settled in 2017. And then the center, in a manner of speaking, was established in 2017, but really remained just a more in paper. Oh, absolutely, and it keeps popping on and off. It's probably in my beads. So thank you for getting that. So anyways, just a little bit of background so that we have been around for a long time and we haven't been around for a long time. So I started in 2020 very quickly. This is our homepage. We hope that you'll come out. It's the easiest way to find us is just in Google. Google the Csomay Center. And we generally pop up because the name's unusual enough. Very quickly, this is my exec team, and we are an interprofessional center while we are housed in the College of Nursing. So we have representatives. You can see Mercedes Byrne-Klug, who I believe was here.
She's coming next week.
Coming next week, okay. She's in the Gerontology program at the College of Liberal Arts and Sciences. Ryan Carnahan next to her is Public Health. Len Sandler, who seems to know a lot of people in the community. I'm always surprised when people say, oh yeah, I know Len. In the College of Law, Amy Colbert from Tippy. But more importantly, as an endowed center, as long as the University of Iowa Center for Advancement exists, the center will be funded. And so I have a responsibility for stewardship. And so you can see I'm bringing in a lot of junior people and then our staff across the bottom there and mentoring them so that when I'm ready to step aside, they'll be ready to step into place. Really quickly, we're a mission-driven center, you can see there, but our vision and what we think about every day is that every older adult receives the care that they want when they want it. Not more, not less, not treatment, care. And so, but you can see our tripartite mission of research, education, and practice, and with a focus on optimal aging.
Leah, I'm
yeah.
going to interrupt, but I'm afraid your mic is making noise. I'm wondering if you could put it, if we could just put it right there.
Okay, that's
Okay,
fine.
I think that'll be better.
Great. This is where I laughingly had said to Lori beforehand, I teach undergraduate students, it is really hard to rattle me. That I have seen it all and done it all, and they are hard to keep. They're a tough crowd. Everything else is like, sure, no problem. We can handle this. So really quickly, we're very, as I said, mission-driven. We have a strategic plan that we follow. Oh, it's because my hands are now over the ThinkPad. I was like, and so when I assumed the directorship in 2021, I brought in a strategic planning company. And this is the map that we follow with the center. This is all available on our website. I'm not going to belabor it now, but just to give you an idea, when we meet with a group or do anything, we really say, does it align with our strategic plan? So today, this presentation aligns with this raising and maintaining the visibility and engagement. And so that was an easy yes when the request came in. Very quickly, some internal things we do related to research is we have a community of scholars monthly meeting, which is a multi-level mentoring structure. The center itself issues 4 grants a year to students and trainees and junior faculty. Sometimes this early money is the first grant that they're going to get. They're baby researchers, is how I think about them. And so I spent a lot of time mentoring them, getting them ready as they advance in their research career to write bigger grants for larger amounts of money. You won't believe how much time I spend teaching people how to write budgets. But it's part of the job, and actually I enjoy it. During the summer, we partner with the Iowa Center for Research for Undergrads, and we sponsor several students, undergraduate students with an interest in research. We, of course, are trying to lure them into research in older adults, and generally, after a summer experience, they just never knew that this whole area existed, and so we're in our third year of doing that and looking to expand it. I also do a lot of outreach into the community. In particular, we're starting to conceptualize the Csomay Center as an umbrella under which we have these three entities you can see there, geriatricpain.org, the Certification Center, and the Thorson Initiative. And as such, I provide strategic direction, staff support, and help them with their sustainability. Once again, on our website, would really recommend that we have incredible amounts of resources on this webpage. You can see here we have resources related to older adults in pain for clinicians, for older adults themselves, and for family caregivers. There are quite a few under the older adults and family caregivers for non-pharmacologic interventions for chronic pain. Most older adults, I mean, it's the wear and tear of life on our bodies, have some form of mild to moderate chronic pain. And oftentimes you are looking for something that will not increase either the number of medications you're taking and or not affect your mental status or your balance, which is really a huge part of a lot of pain medications really can affect that and place you in greater danger. So I'd really recommend you go over and take a look at that. Lots of great resources. The Iowa Department on Aging and Disability Services now links to this, and many of the area agencies on aging are also listing these resources. The second piece is the certification center that comes in under the Csomay Center, and all of the direct care workers in the state of Iowa are certified through the University of Iowa Certification Center, and this gives us a really great entry into working on the curriculum and then the testing. So your CNAs, your med assistants, your medication assistants in long-term care facilities, all are certified.
So do you work with nursing homes then?
Yes, we do.
Sometimes they don't do very well.
Well, there's a major crisis going on in long-term care at this point in time, coming out of COVID, yes. And lastly, the Thorson Initiative under our umbrella was a significant gift given last year by J.D. and Jill Thorsons, once again, alums of the University of Iowa, who really wanted us to double down on that optimal aging, and particularly starting earlier in the trajectory. J.D. was a longtime gastroenterologist, you can see there in Mason City, and he says, when somebody turns 65, it's too late. You need to be talking to 40-year-olds about how to start those healthy practices. And so we've been really fortunate in the year and a half since that grant was made that we have been able to engage across the state in attending health and wellness fairs, and we do tables at any kind of senior event throughout the state, just really focused on that, good nutrition, activity, remaining active, engaging with your community, remaining active socially as well. So that's been a really nice alignment with our mission. And after I arrived here, I discovered not only are we the only center related to aging at the University of Iowa, but we're actually the only game in the state. In other words, both of the three Regents universities, both Iowa State and the University of Northern Iowa, have gerontology programs, but no center. And so we do outreach to both of those universities. We have yearly meetings. We talk about what we're going to be focusing on. We think about how to work together to cover the state, and particularly because the extension department is at Iowa State, and for rural areas in particular, that's kind of the community hub, really saying, can we get some optimal aging information into there and then disseminate it across the state. Because when I'm meeting with particularly entities outside of Iowa, so for example, we do work with AARP, we do work with the Alzheimer's Association, and other national entities, I often lean into them by saying, you really want to work with us. Our center has over 2,000 contacts throughout the state. If UIHC's data is to be believed, which they're pretty good people over there, 90 of the 99 counties have presence. We have presence in there through our alumni from either the College of Nursing or the College of Medicine. And that at this point in time, because Iowa is a relatively population-wise small state with a population of 3 million people, and of that there's maybe 500 of us in gerontology. That's a small denominator. So, and I think I've talked to most of them in the last 3 years. So we talk about our partnerships with all the major gerontology stakeholders in Iowa. So you were asking about some of our partners. This is just sort of a snapshot. And you can see there both within and without. Really the biggest thing that I think the Csomay Center does is as a connector. Oftentimes there are community needs related to older adults, but that whatever that stakeholder group is doesn't know how to find what they need within the university. The university can look kind of big. And because we're in the university, I oftentimes know about programs that are looking for example, projects for students or ways for them to do some community outreach. And oftentimes a big part of what we do is bring the two groups together. So at this point in time, I've recently funded a study working with Johnson County where they're creating a survey to assess how age-friendly older adults in the county think Johnson County is. Not what the professionals, but what older adults actually think how age-friendly the county is, with the idea that it will be tested in Johnson County, and if the survey is found to provide meaningful information, it'll be scaled up across the state into the 98 other counties, and then we can really put together a map of the state of Iowa in terms of age friendliness in the community. So this is just a coming attractions, trailer of coming attractions. We are rolling out a membership structure. There's never been a way to belong to the Csomay Center before I came. And it says rollout in the fall, but we're having some website glitches. It's going to be a rollout at the beginning of the year. We're doing a soft rollout within this fall. And we have for community partners, such as yourself, you can see here we have 2 different tracks that you could either join as an individual or you could join as a church if you were interested in being a member of the Csomay Center. And what would that involve? There's no cost for the membership. However, there will be periodic times we may pull a call out that we're putting together a focus group where we would like to hear stakeholders' opinions on certain things, maybe a new project we're thinking of working on, maybe just taking the pulse of the community to say, you know, so what do you think about sidewalks in Coralville? You know, and things like that, which you don't think as being something that university-centered, but it can make a difference with older adults getting out of their homes and being able to be part of the communities and things like that. And AARP in particular is very focused on sidewalks. And so we can do some survey work for them as well. Really quickly, this is how to find us. And as always, that's the brand. Okay, Lori, I don't know. Maybe if we go ahead and drop the slides. I'm always on a Sunday in a church, I'm careful that we don't make it too much idolatry related to the university. I'm coming from Penn State where the shrine, you know, or the Nittany Lion was a huge deal. And we often thought that if they changed the football games to Sunday morning, the whole place, nobody'd go to church. So I want to be sensitive to that. So.
I'll just turn that off.
Okay, that's great. So any questions before I do, this is the inflection point I told you about, the pivot. Any questions related? Yeah.
I couldn't read all of the organizations, but do you have any groups or programs that specifically include LGBTQ plus seniors?
We are meeting now with some community members with an interest in that area and really starting to talk about what would be, we're supporting researchers looking in that area, but also asking the questions of do we need to provide support for like going out to some of the community events, having a Csomay Center table there? Maybe using some of our space, our conference room, for example, to open up coffee hours. We're really open to and talking to the community. How do they see the center interacting with that?
And is there any training for the physicians and the nurses on?
Outside, there's actually, I can only speak for nursing because that's the only curriculum I know well. And we have a significant amount of curriculum related to this at this point in time, as we do similarly having to do with different racial and ethnic subgroups and things like that. One of the things I've appreciated the most about nursing through the years is this idea, and it's hardwired into us from the very beginning, is meeting the person where they are. I can't make that claim for the larger healthcare system, but I can pretty much. There's a lot in ways in which librarians and nurses have a lot in common besides the fact that they're just heavily female gendered. And I think it's this idea of having a bent towards subversion. Let's just put it that way.
Connected with libraries too, so great.
Yeah, exactly. Let's just leave it at that because I know this is being live streamed.
So how difficult is it for the elderly to get health care in Iowa? Because I read something recently about the decline of availability of health care across the state is astronomically awful.
Well, first let me start with just using a teachable moment that the word elderly is now is considered pejorative, that we use older adults. And so it's a time for all of us to kind of check our own language. So to think about it, you're still an adult. You haven't become different. And as a matter of fact, when I talk about spirituality, what I'm going to talk about is that it's a function of who you are as a human being across your life course. It doesn't change just because you're older. So to that point, but to your more important point about healthcare deserts, they are real in Iowa, and not just for older adults. I know this group would not be impacted directly by this. You don't want to be pregnant in rural Iowa for the fact that there's very little maternity care out there as well. So the healthcare itself in rural areas, but it's not just Iowa, it's all rural areas. And it's a function to a large degree. It's not that clinicians don't want to practice in rural areas as much as the business model of current healthcare, and particularly healthcare education, the cost of it, and the size of student loans that many young clinicians are carrying cannot be supported by a rural practice. And that's just kind of the bottom line. You will hear a lot more smoke and mirrors, but it's a business case, really, at the end of the day. So, yeah, we're fortunate in Iowa because of the University of Iowa College of Nursing's very large nurse practitioner programs, and because they are, for the most part, online and available in rural areas, they allow nurses who already live in rural communities to stay there, increase their education, and then be able to provide primary care. And that's why for older adults in particular, most of the chronic illness management is being carried out by nurse practitioners in rural areas.
You have a really large list of participating organizations. So using one for example, like Meals on Wheels, how do you interact with those organizations?
Absolutely. We actually interact with them through the AAAs, through the area agencies on aging, or through, here in Johnson County, we do it through the Johnson County Senior Center. And so that being said, on the national level, I was just at a conference in Austin last week where I was talking to the national Meals on Wheels people about what's going on in Iowa, because sometimes it's really hard for them to get a boots on the ground, view. What I was talking to them about is the providing education to Meals on Wheels volunteers for wellness visits, so that they're not just dropping off a meal, but also, have enough information that they can scan the home. Does it look like there's self-neglect? Is this someone who at least a flag should maybe be raised a little bit or something?
We don't get any training like that though, and it worries me. I'm new and it
Right,
worries me.
right.
I've seen things that are wrong,
Right.
really wrong, and have mentioned it, and they kind of say, well, no, we don't know what to do.
I know. We're talking to them. We really are talking to them about that. And remember once again, that timeline, that really 2020 was when the center became really active, 2021. So we're 2 years into conversations. They're very interested. The question is, how much can you expect a volunteer to sign up for, the training piece of it. So Lori?
So I'm very eager, we have lots of questions, I'm sure, but
Okay.
I'm really eager to hear you talk about spirituality and aging. So
Great.
I'm wondering if I can help with your segue there.
Well, thank you. I wanted to be responsive to the crowd, but thank you for the nudge, friendly nudge. First and foremost, I thought what I would do is I would talk a little bit about my clinical practice, in that I'm a second career academic. And what I mean by that was I was a bedside nurse for 20 plus years before I actually went back to graduate school and got my PhD. I was in my doctoral work at the same time my kids were undergrads. And so to your point about women is, we're built for endurance and distance is what I had a friend who decided to become an Iron Man in her 40s. We're built for an endurance and distance, and so women have more than a second act or a third act. And so for years as a nurse, to the earlier point that I made, I had, in bringing in what you've just said, at that point in time when I went through nursing education in the 70s, we got no spiritual training. And yet we were stepping into people's lives at their most vulnerable and oftentimes at their most existential, whether it was in just getting a diagnosis, whether it is in taking a turn that was unexpected in your health. And just over the years, because I was open to those conversations, they would occur. And particularly because I worked primarily in critical care for the first half of my clinical practice, and then the second half, I switched over to hospice and palliative care. So I was definitely in that kind of liminal space of, what's going on. The uncertainty is high. Am I ready? And it was, in the end, it was dealing with that with no training that really brought me to the point of going back to school. And I thought what I'd do, and I talked to Lori about this before, I'm going to tell you two stories, and I think that it will encapsulate it. As a hospice nurse, I was visiting an older couple. This is not their name, John and Mary. And this was in Florida. They were from the Northeast. John was a longtime engineer, and Mary had been a stay-at-home wife. John had no religious interest or background. He was a thoroughgoing engineer. If you couldn't weigh it, measure it, whatever, it didn't exist. Mary had a very deep and meaningful faith, and had been a very lifelong member her background was Catholic, and John's was engineering, and they were, in a sense, religious systems of a sort. And as John's health declined, Mary it had been a long and loving marriage. They had been married 50 plus years. They had 2 daughters, my age. And she became more and more frantic that, it was not going to go well for John at death. And, so she ginned me up to take as everyone should know, you know already this was not going to go well. But I raised the question because in hospice practice, we met all of the domains of the individual, from the spiritual domain, the health domain, the social domain. We really covered them all. So one day, and I had John as a patient for probably a good 3 months, which is an unusual length of time. I knew them well. I loved them. We had gotten to that point. They were important people to me, and I think that they loved me as well. And so I very quietly raised the issue with John to say, because we had chaplains on our service that I could offer if he wanted to have a spiritual conversation. And he went ballistic on me. Absolutely went ballistic on me, that he was fine, he had no problems, he was going to take it as it came, and I could just get off his back. Now, it could have been, it wasn't safe to say that to Mary.
Right.
And I was willing to be that person to take it, and I backed it up very quickly. So fast forward a week or two later, when John actually died, one of the things that we did in hospice is I would wait a week or two and I would make a final bereavement visit with the family member of whomever. It was considered a closure visit. Our psychosocial people, our bereavement support people, would continue to carry them for a year, but the nurse made this closure visit. And so Mary and I were sitting on her couch, and as we often did, and chatted, and I was holding her hand. As I said, it was a very, it was a warm relationship. And she looked at me tearfully and she said, Leah, I just have to believe John is in heaven now. And I tried to keep it in. And all of a sudden, the biggest guffaw I've ever had just burst out of me. I knew her well. I knew humor was appropriate. And I just looked at her deadpan and said, wasn't he surprised? And then we're both on this, couch together. I'm over on one side, tears running down my face, laughing, and she's doing the same thing as we contemplated John standing before the pearly gates. And so I think what that points in that story is, and it was something that was really, I had to learn. I had approached hospice and end of life with the idea that there were no atheists in foxholes. And that was not correct. The truth is that if spirituality has been important to you earlier in your life, it will be important to the end. But if it was not important to you, it was very rare that you would turn to it then. That instead there would be sort of an open-handedness of I'll take it as it comes, or I'm not expecting anything. And that was an eye-opener for me. And sometimes, personally, that was difficult, particularly when I got emotionally attached to someone like John. But once again, you meet the person where they're at. It wasn't about me. It was about them. The second piece, I'm just going to very quickly share, and this is where we're going to pivot. So remember, I've got all this clinical practice. I've been talking to patients and families across the years in some of their worst places. But I also told you these questions took me back to school, and so this is the little paper that could, and as a matter of fact, I looked up this past week. As of 10/24, this paper has been cited 206 times, 7 times alone just this year, and this was published in 2006. This is very long in the tooth, but it continues. And I think it's because there really hasn't been a lot in nursing that's come out since this, in which I collected at that point in time all of the literature related to how nursing looked at spirituality and did an analysis and then created a conceptual definition for it. And so it starts with a story, which is story number 2, and I'm going to read it to you because if I told it to you today, like the John and Mary story, I'm telling you having had probably 15 years since then. And so the story, our memory is malleable, right? The story changes. I will tell you though, laughing on the couch, really there. And John's anger was really real and scary. But for the details, but in reading this, I'm giving you, this was a recent event. So the story goes, as a hospice nurse, I was making a routine visit to a newly admitted patient. He had been admitted after a long battle with cancer. Still alert and oriented, he was sleeping more and interacting less with his environment. After my initial visit, I presented his case at our interdisciplinary team meeting at the hospice. I reported that things appeared routine for his diagnosis, and I expected him to be my patient for some time. His oncologist, however, was our team's medical director, and he was present in this meeting. He stated that on the basis of recent blood work, he did not believe that the patient had much time left, and that he informed the patient of this. He had told him. In my interviews with this gentleman, he hadn't mentioned this conversation to me. So at my next visit, I stood by his bed quietly, and I watched the sun play against his cachectic. He was wasting, looking like a concentration camp member. His cachectic, jaundiced body. He was alert, but very still. He said to me, "So this is it." He had told me previously that he was an engineer by training and had a strong faith. I answered, "Yes, it is." I was filled with a sense that we had stepped out of measured time and into soulful time. Nothing changed and everything changed. He was silent and I was silent. I was filled with a sense of the incredible privilege that it is to bear witness to this moment. After a time, I gently asked him, "Are you ready?" He was silent for a moment, and then he said, "Yes." Although I visited his home daily over the next few days, he never spoke to me again. His family reported a pulling away and drawing inward that's often seen in the dying process. He died quietly at home several days later. And I can still, in the sensory memory, even reading the story is, I can still see the sunlight, how it was dappled across he and his bed at that moment. But that gives you that idea of stepping out of Chronos, that measured time, into Kairos, that soulful time, is very real, particularly in hospice. And that was what drove me towards this idea of, I don't know enough. I don't know enough. And so through a process, and I sent a PDF to Lori and Bob so that if you'd like a copy of this paper at a later time to look at, it would be available to you. So what I did at that point in time was I collected all of the literature in nursing related to spirituality at that point in time and did a narrative analysis, really highlighting the features, but I also went to just a dictionary. What do we as an understanding? So I used the Webster's New World Dictionary of the American Language and developed criteria for the concept of spirituality as nursing practice will understand it. And it had 5 criteria, and one is that, and as I say these, I want you to turn internally and validate or not whether these feel real to you. The first is that it's an experience that's intrinsically human, but it's not limited by cognitive ability. It's what makes us human, but it is not more or less based on our cognition or cognitive ability. The second criteria, it incorporates the metaphysical components of ontology, the nature of being, who am I, with teleology, the ultimate purpose or aim of my life. The third criteria is that self is transcended. The fourth criteria is that it is connected, self is connected with both the corporeal, the things you can see and touch and feel, but also the incorporeal, nature, a supreme being, a force, an energy is experienced. And number 5 is a very Western take on it, because the number 5 criteria is it may or may not involve religious structures and traditions. And why I make that designation is that somewhere probably between the 70s, when spirituality was first being measured in healthcare, and the 90s, spirituality started as a small subset of religiosity. That people who were measured on religiosity and spirituality would score high on religiosity practice, common praxis, going to church, belonging to a religious community. Depending on your background, bringing potluck, bringing food to church. You know, those religious practices. Whereas spirituality, people who say there is something outside that I cannot define, but it is real, was a relatively small subset. And the shift came that spirituality grew larger until it actually subsumed religiosity. It's interesting when you look at the social science measurement over that period of time. But the caution, particularly as a clinician, because we take care of people from all sorts of different backgrounds and places, is this is a Western phenomenon. And so in particular, the Muslim world is very, they experience all of their spirituality within their religious practice. And so if you ask them about their spirituality, it can be offensive. You do better to ask about their religious practice when you're trying to do a spiritual assessment, which we are supposed to. Bob?
With that in mind, I'm curious what you think the causes and effects might be of what I perceive as a rapidly growing phenomenon, and that is people in their obituaries in paper, either the person who's dead or the family saying no funeral.
Mm-hmm. It's really interesting, and actually where I first picked it up and started watching it was, and actually this goes for weddings as well, that when weddings and funerals moved out of the church, when outside venues began to be, and I think that maybe that was that transitional point. Previous generations would be transitional point might have been when we stopped burying people around the church, right? It showed just a change. One could say progression, but I prefer using change. I think it's a more neutral term, in just how we perceive who we are as social beings in a community. So the really, what I always come back to in situations, I'm a social scientist, so all of this is fascinating to me. I just watch it, it's fascinating. You know, I don't assign a valence, negative, positive to it, it's just fascinating. But I think there's repercussions to your point, right? If we move funerals outside of the church into a funeral home, was it easier to say, you know, I don't think we really need a funeral at all? Not understanding that we as human beings we create rituals to get through tough points in life. And in leaving behind rituals, we've left behind what was actually, over the millennia, a pretty effective coping mechanism.
People aren't getting help grieving.
Yeah. Absolutely. My most recent work, actually research, and I'm in a funded study with Mayo now, is related to prolonged grief disorder. And that's exactly to your point, looking at people, and we're using a trauma-informed intervention to treat this prolonged grief disorder. I'm going to look at the clock just really quickly, because I know when I start talking about my science, I lose all set of time. And actually, Steve, you know what? Could you be a timekeeper for me? Thanks, appreciate it. This is my husband, Steve, in the back. And that way I can really focus on what's really interesting about grief is that we think of it now with two phases. There's acute grief, and then there's chronic grief. And those of you who have been through it, if you look back, you can kind of say, yes, there's that early grief in which you can't even imagine opening your eyes that day. And any thought of the lost other brings these just emotional waves across. But then over time, the day-to-day routine, right? You have to get up, you have to get dressed, get cleaned, eat. It kicks in, and what you find is, and 6 months is usually considered, and there is no normal human response. So what they mean by 6 months is, if you measured 100 people, probably between 25 and 75, I'm doing the normal distribution curve. The people in the middle, at about 6 months, life is starting to go on. You're having intermittent moments versus continuous moments. But for some people, they don't, at that point, don't make that shift. And so they remain in that acute grief phase past that into the year, 18 months, sometimes into 2 years. And you may know individuals or may have been at that point and really felt that. And so we were thinking, because the symptoms of PTSD and the symptoms of prolonged grief disorder are similar in that there is this memory body reaction that goes on. Could we use this intervention to break that moment so that you can have the memory, but you now don't get the automatic physical response to the memory? And we actually showed significant improvement with prolonged grief disorder, and we're actually on our second study related to that, because what the first study taught us was that oftentimes it was that the person had not grieved for a previous death, to your point. And so that we were actually having to go back and grieve, and particularly if the death had been in childhood. And so our current study, we're actually, for family caregivers, we are identifying them prior to this death. In other words, when we're working in oncology clinics, when their family member receives the terminal diagnosis and death is, soon, to just screen them. And if they screen positively for existing prolonged grief disorder before this death, providing the intervention there with the hope that then the skills they learn from the intervention they will carry forward. And that brings grief is that really it gives us that idea of that metaphysical, right? That there is something, we are more than a physical body. There is this, entity, the spiritus, whether you call it the pneuma, the numinous, some refer to it. There is something more. And, are we really, as a nurse, am I really providing care to that? Do I know enough? One of the things, the best parts I found about being a hospice nurse was I actually received a lot of training. I was in the Tampa Bay area. There was a lot of refugee resettlement in that area. There was several large organizations there. So we had an infusion of Hmong people in the early 90s. And, how much did I know about Buddhism at that point in time? Really very little, and particularly death practices, which are necessary. And then in the 90s, we got an infusion of Bosnian refugees who could be, for the most part, Orthodox, but there was some Muslims in there as well. And once again, really learning those different death. Because sometimes even though you say this is a Buddhist practice, well, is Buddhism in Southeast Asia the same as Buddhism in India? No, it's not. It's very different. So do you understand that individual's faith practice enough so that you, one, don't offend. That's what I was sort of always focused, that I not inadvertently offend, but then two, also be able to assess, is that need being met, and how do we address it if it's not? You know, who do we bring in to provide those added? Well, anyway, I think that we have just about 8 or 9 minutes for some questions related to, so coming back to spirituality and aging, all of a sudden, let me just make, this is kind of the summary, like, oh my gosh, I told him I was going to talk about spirituality and aging. Have I talked about it? I think if you could take one thing away from today is that truth that I learned, and that is, it doesn't change. Aging doesn't have anything to do. The spirituality belongs to the person, and it will be the spirituality they've had their whole life. And so
I have a friend, long since retired. She was an oncology nurse, and she would say that almost every medical practitioner had had some spiritual experience with a patient at the time that they passed in the room. And she goes, most of them are too afraid to ever talk about it. And I don't know if there's any research about that.
what I find, I can only speak from my own experience, but that's true. That's absolutely true. I don't think it's so much fear, believe it or not, or maybe just for me it wasn't so much fear, as it was something very precious, and you didn't just share. It was a gift you had been given. The thing I found fascinating when I went to home deaths, which was what hospice was, I'd always seen death in a hospital, and death in a hospital is a failure. We lost patients, the very words in it. It's a failure. A death at home, in a manner of speaking, is a success. And what I mean by that is that the person had the death they wanted, which everything in the hospital really, really works against that. But what fascinated me was what is termed, different disciplines call it different things, but in nursing it's called nearing death awareness. And it is that existential line is not hard and fast. That I'm alive and now I'm dead line can be very fluid. And that shocked the living daylights out of me. So what do I mean by that? It was not uncommon, particularly in cancer patients who have sort of a very slow trajectory and predictable there towards the end, that they would start dreaming about, it was train stations in the generation I was taking care of. We're going to be dreaming about airports. Hate to tell you this. Just in case you're triggered by airports. But it was always, of course, the theme was journey, right? So they would be dreaming about, or standing on line with luggage. There was some very classic, and this cut across many patients that I would talk to, that their body was sending them a signal, that a journey is approaching. It was oftentimes somebody would come and give them a message. Oftentimes it was a family member, someone they loved. Sometimes there were angels. Sometimes it was Jesus, depending on, kind of their religious tradition, standing at the end of the bed and giving them some kind of message. Sometimes it was not yet, you're not yet. And they would last a week or two longer than I had told the family, like, no, I think we're within 24 hours. That whatever the message they were getting was truer than the one that I'm looking from the outside at. And I could always give sort of a biophysiologic argument for that, that as their hormonal levels were rising and falling, it was very typical. We're at our lowest diurnal pattern at sort of about 4 a.m. All of your hormones are the lowest. Everything is, that's why you tend to sleep deeply at that point. And then they start to rise and it wakes you up when they hit a certain point. And so, I would tell myself all of these things. Oh, it's interoception. Their body is sensing, that these levels are already low and now they're going like really low. But it was their experience, whether it was chemical or not. I actually learned to ask them about it over time. At the beginning, it would always be some of them might tell me. After a while, I started asking them because I found it such a strong indicator of approaching death. And they would, cognitively intact people would sheepishly tell me, like, I thought I was going crazy, but, the other night my dad came and he told me, and things like that. But as I normalized it, they found great relief to be able to talk about it. And then sometimes I would either ask their permission, do you want me to tell your family? Or, have you talked to your family about this? This is really, because most of the time they were comforted. It wasn't scary. It wasn't, so yes, there's definitely that existential element. I'll tell you as a nurse, though, the scariest thing I ever did, by the state of Florida, I was empowered to pronounce people dead at home. And a registered nurse can do that. I could do it in the hospital as well, but in the hospital I had monitors and things I could look at. Remember, I want data. And at home, I was like, oh my gosh, what if I pronounce somebody and they're not actually dead? Every middle school story that they tell around campfires, right? Oh my gosh. But I will tell you, you can tell. You can tell. You can walk into the room that the person is not there. You can tell. It was never a question. I've just gotten the 2-minute warning. And so one last question. Lori, I haven't called on you.
Yeah, so I was intrigued by what you said about community partners for the center. And I'm wondering if you could elaborate about, if New Song is willing, how we might be in collaboration.
Thank you so much. Since this is a new program that we are developing, what we're going to do as we set up the membership structure at the beginning of the year is hold an open house. And we're going to talk to the community partners, anybody who comes, and ask them what would a meaningful, interaction with the Csomay Center. Would you like to be, and we have different levels of, would you like to be on our newsletter, recipients of, where we're talking about different topics related to older adults. Would you like, you can do it actually now, you can go over onto Facebook and look for us and you can join the group. And we're posting information there. We're talking about what's going on in the center. We do social media in terms of, Facebook is pretty stable, but Twitter is just a mess. So we're gearing more towards LinkedIn for a second place. We try to hit, because it's different slices of people go towards different platforms. But so there's that sort of thing. When we are looking for, one of our researchers wants to put together a group that a lot of research now has to have community stakeholders at some part of the research, whether in a co-design role or whether in you bring your findings back to the community and ask them to validate it. So we have a lot of opportunity for that sort of thing, that we could put together a registry. I had mentioned to you, I think before, that about putting together a speakers bureau. So you're doing a group, any kind of community group, and could somebody come out and maybe talk about their research? Let's say you wanted to do some kind of community fair of some sort. And could we come out and set up a table and then provide information related to optimal aging, be available to talk to people? There's a lot of different things, besides the fact that we're just a community. We're just a lot of really good people. You don't go into gerontology if you're not people-oriented. Yeah? So, well, anyways, thank you so much for your time. Really appreciate the light.
You that next week we will have another member of your center. Her name is Mercedes Byrne-Klug. Some of you, I'm sure, know her. She was director of the School of Social Work. I think she sort of phased out of that, but has a long-standing interest in both spirituality and aging. So that should be a good session, too.
Right, and she's a social worker, so what you're going to hear is a different disciplinary perspective on it as well.